I'd like to thank the organizing committee, especially Dr. Nuran, for the kind invitation. I'm Dr. Eman El Bakoury, and this is actually a quite large and long talk. I hope I'll make it short. So I'm going to talk about the power of radiologic pathologic correlation from image to diagnosis. This is my agenda. I have no disclosure. We all know that currently the percutaneous biopsy has become the gold standard for evaluation of the...
Put your mic, is the sound is not...
we all know that the percutaneous biopsy had become the gold standard for evaluation of the breast cancer preoperatively, and from which we will talk about the ultrasound-guided biopsy, which is currently, as said before, widely used. It's very common, easy for the patient, and available. Ultrasound-guided biopsy previously was for evaluation of breast masses. However, currently, because of the high ultrasound technique, currently, breast ultrasound-guided biopsy can be done for evaluation not only of breast masses, however, non-mass distortion and calcification can be evaluated as well. So the initial results upon evaluation of the ultrasound was about 100%. However, because nothing is 100%, it drops down to 96%. So actually, the radiologist should be aware not only with the ultrasound biopsy techniques, however, with the concordance that occur and the appropriate management whenever had been done. And for increasing the sensitivity of the core biopsy and reduction of the discordance ratio, there is aspect to be considered, which is the targeting, the sampling, and final virus category assessment. Regarding the targeting, actually, Dr. Mona, I think, she talked about the difficulties the radiologists meet when doing the core needle biopsy, which is the deeply seated, the most superficial, the dense lesion, and the dense related parenchyma. And because of these difficulties, sometimes you are off-center and it looks like you are within the target lesion. So you have to document your biopsy using 3 shots. Number one, when the cutting notch is within the lesion, and remember that the cutting notch should be including at least 75% of the mass. Number two, when you advance the cutting edge, that's to say when you fire the needle. And number 3 is a perpendicular place in which the tip of the needle is seen within the mass. And do not forget, as seen before, the imaging of the cores whenever you have an ultrasound-guided biopsy for calcification is very important, okay? Just to document the presence of calcification, and sometimes this calcification actually dislodge within the jar, so you document the presence of calcifications within the specimen you took. And do not forget the post-biopsy marker, which is very important. I hope it will be soon the area of concern in Egypt. Number 2 is the sampling. Whenever you are sampling a lesion, you have to sample the most suspicious one. Do not leave the most suspicious to biopsy the less suspicious one. So when you have a speculated mass and suspicious duct, do not leave the mass to biopsy the duct. And the number of cores are very important in avoiding the discordance. You have to take at least 4 cores, okay? I have biopsied many cases in which the cores is not enough for immunohistochemistry twice, okay? One of the cores should be intact, and when you are dealing with suspicious calcification and you are going to biopsy this calcification using ultrasound, you have to be sure that the calcification or areas of concern that you are targeting on ultrasound is concomitant with that had been seen in the mammogram. So please put a BB marker while the patient is sitting position, not supine position, because changing of the position will change the BB marker. Finally, we reached the virus category, and when we are talking about virus 3 or 4E lesion and you got a benign pathology, this is a concordance. Despite of being 4A lesion, then you have a chance of 80% incidence of benignity. And when you are going to talk about 4C and 5 lesion and you got a malignant pathology, again, this is a concordance. However, if you have a virus 4B lesion and the biopsy got a benign finding, please re-evaluate both the biopsy and the radiological finding. In addition to the virus category, you have to ask yourself if the pathological data gives an explanation for the radiological one. For example, when you are going to biopsy a distortion and you got sclerosing adenosis, this is not discordance, this is a concordance. And the same goes to the papilloma when you biopsy an intraductal lesion. So whenever you have a concordant benign finding, according to the institution regimen, you may follow this patient after 6 months or 12 months in some institution, or you may let the lesion go just in cases of traumatic fat necrosis, for example. And whenever you are going to biopsy a suspicious finding and it turned out to be a malignant lesion, of course, this malignant finding will be dealt accordingly, either by surgery or neoadjuvant chemotherapy, which is the same actually whenever you got a discordant malignant finding upon biopsying of a low suspicious or a probably benign finding and it turned out to be a malignant, then the same will go, this patient will go whether to surgery or neoadjuvant. However, you have to check two things. Number one, and the least important, is the missed data in the technique that had been evaluated as probably benign finding. This is the least. And the most important, actually, to review your study again, because we, as radiologists, whenever we are dealing with a low suspicious finding or a probably benign one, may discard some lesions as a probably benign finding, such as fibroadenotic nodules or intramammary lymph node, rendering this lesion that had been identified as suspicious, multifocal, or multicentric. This is the cases of triple negative, high-grade carcinoma, papillary, mucinous, medullary, and many other rare subtypes. When you have a discordant benign finding, actually you have plenty of options, including repetition of the pathology, repetition of the radiology, repetition of the core biopsy, or going through vigorous core, such as the vacuum-assisted or even excisional biopsy. And this is the case, as Dr. Mona said, of the B3 lesion, the traumatic fat necrosis, post-surgical scar mastitis, and other rare entities. So let's go into a number of cases to apply what we have said. This is the first screening for a 43-year-old lady. She had a group of pleomorphic calcification implicating the outer quadrant of the right breast. And this is an Eklund view in which the implant is displaced posteriorly. However, in the non-displaced views of the MLO, we can see these groups of calcification implicating the upper quadrant. Upon displacement of the silicon, we got another group in the lower quadrant. So this is actually a multicentric process. And it's a class 4C calcification. So number two is to pick these calcification using ultrasound, and here the ultrasound actually piece of cake calcification. Upon targeting the calcification, fibrocystic changes with usual ductal hyperplasia yielded. This was actually outside Egypt. And this was, of course, a discordant finding. So this patient came back to Egypt to seek medical advice. I reviewed the mammogram, post-clipping mammogram, in which the clips is well concordant with the suspicious calcification in one view. However, in the other view, the clips is abutting the calcification, which is fine, actually. Whenever we have a clip within 1 centimeter within the target, it's okay. However, with such benign pathology, we think of reviewing or repetition of the pathology. And the same goes with the MRI, in which the signal void artifact of the clip is just abutting the non-mass enhancement caused by this calcification. So we repeated the biopsy, and it yielded high-grade DCIS with focal invasive component. So the post-biopsy clip is not a fancy. Actually, it's very important in preventing the radiological pathological discording by serving as a visual marker for the biopsy site. Next is a 58-year-old lady. She presented with right breast lump, and the mammogram and ultrasound showed a bilateral suspicious finding, mass on the right and non-mass on the left. The right biopsy showed infiltrating ductal carcinoma, and the left showed an ADH. Of course, these are bilateral suspicious findings, so we have to shift to MRI to evaluate this patient, in which the piece of cake upper central right breast speculated mass had been detected. However, in the left, we didn't pick up any enhancement regarding the alleged non-mass present in the left breast. So upon reviewing of the non-subtracted image, we can see the aggregation that takes an oval shape or round shape in the MRI. So despite of the discordance here between the MRI at the study, the mammo ultrasound, and the pathology in another study, okay, we went for another shot of the mammogram because the patient had no mammogram, and here we can see the well-capsulated breast within breast appearance of the left breast, rendering this lesion is not a non-mass, it's a hamartoma. So still there is the debate with the radiologist, the pathologist, and we called the pathologist to ask about the ADH. And for this, the pathologist actually imaged the slide she had, and these were very scanty cores. And for correlation, she sent me another proper core image. So this is the proper core that should be obtained. And the pathologist assigned left breast hamartoma. I will skip the case for the sake of the time. So the appropriate number of preoperative core needle biopsy specimen for analysis is usually 4 or more, and it can reach up to 8 when dealing with suspicious calcification. This is a 38-year-old lady presented with left palpable lump, and here we can see the ultrasound showed bilateral non-mass that's present with variable degrees in both breasts. The left one had been biopsied and showed infiltrating mammary carcinoma. Of course, infiltrating mammary carcinoma carrying the risk of lobular carcinoma. So because of the lobular carcinoma being bilateral multicentric in many cases, we went for MRI. And here we can see the clumped diffuse non-mass presented in the left breast. However, morphologically similar to less extent non-mass can be seen in the right one. So we assigned virus 6 for the left one, virus 4 for the right one, and asked for biopsy. And upon biopsy, it showed right breast fibroadenoma, which is completely discordant. But actually, the oncologist discarded the discordance and went for neoadjuvant chemotherapy, and here we can see the complete response in the right breast and the partial response in the left one. Let me remember you with the baseline images, and upon reviewing, here we can see the well-defined, initially hypointense, non-enhancing paraareolar mass that had been biopsied before as fibroadenoma. So actually, we got fed with the oncologist, called the surgeon, asked for biopsying of the right breast, and it came out with complete chemotherapeutic effect on previous malignancy. So actually, before biopsy, you had to review the image. It's very crucial. For ensuring the accuracy of the cancer detection, we have to be sure that the radiologist and pathologist are examining the same disease. Next is a 48-year-old lady with left pathologically proved locally advanced breast cancer. This is her preoperative MRI, and here we can see the diffused clumped non-mass enhancement, skin thickening, enhancement, and ipsilateral suspicious node. Of course, this had been treated with mastectomy, and the patient actually asked to do a post-operative MRI. I don't know the reason, but this was good. So the post-operative MRI showed the segmental non-mass enhancement present in the right, and we tried actually to triangulate the lesion because the ultrasound was completely negative, and we got a non-proliferative fibrocystic changes, which is completely, again, discordant. However, the patient is clinically free, she has no complaint, and the biopsy was negative, so we scheduled 6 months later on follow-up. And here is her MRI 6 months later, rendering the non-mass transformed into clumped, diffuse non-mass together with the enhanced thickened skin. It was a piece of cake in the ultrasound, and the biopsy showed invasive ductal carcinoma. So the non-mass actually is not a dilemma upon diagnosis alone, it's also a dilemma in the biopsy because it's less well-defined and can represent a very wide spectrum of benign and malignant pathologies. So the sensitivity upon biopsying of the non-mass actually using core is decreased. This is a 53-year-old lady complained of right breast lump. She had history of ipsilateral malignancy a long time ago. And here we can see the well-defined oval shape and note the density or the heterogeneity of the lesion. It's morphologically similar to the fat. So this is actually most probably a traumatic fat. However, it's palpable and newly developed, so we decided to biopsy the lesion. Upon biopsying, it showed an ADH. We are agreed whenever we have a suspicious finding, okay, we should review our imaging studies. So we reviewed the ultrasound and it turned out to be an ill-defined component just related to the well-defined one. And upon reviewing the mammogram, which was completely dense, we noted this newly developed, again, well-defined mass. So these are suspicious findings that can be discarded initially. And for the density of the mammogram, actually, we had to be sure that this is a solitary lesion. So we went for MRI, and here we can see the fat within the mass or lesion that's present in the MRI. So the sensitivity for malignancy here, it drops. And after MRI, we asked for repetition of the core. However, the surgeon went for excision after wiring, and we got low-grade intracystic micropapillary carcinoma with cholesterol granuloma. Actually, in the literature, we couldn't pick up any association between the cholesterol granuloma and malignant finding. So this is mostly a case report. However, the tip here is for whenever we have a suspicious biopsy result, please revise your imaging again. This is a 40-year-old lady with left mastalgia, and here we can see the groups of calcification of pleomorphic type, one here and one there with questionable in-between scattered calcification. In a trial for biopsying of this calcification, we got this microlobulated hypoechoic mass. Upon biopsying of this mass, it yielded an ADH. So this is actually a discrepancy between the size of the lesion upon ultrasound and the mammogram. So we went for MRI, in which we can see this segmental central inner non-mass enhancement correlated with the full extent of the calcification that's present in the mammogram. And upon mastectomy, it shows DCIS. The ADH upgraded to DCIS. Type, I'm sorry. I will skip for the last case. So this is a fibrocystic changes, and we can see the fleckers of calcification between the cysts, and it was correlated to these obscured masses with round calcification. We assigned BIRAT 3 and have 6-month follow-up. After this, the calcification had been progressed, went for MRI, and here we can see the non-mass creeping between the cysts. So actually, we biopsied this lesion and turned out to be fibrocystic changes with no atypia, no malignancy. 6 months later on, this non-mass creeped actually slightly to the nipple. And upon vacuum-assisted biopsy, it showed fibrocystic changes with focal flat epithelial atypia, which is concomitant with the excision biopsy. So the vacuum, as said before, is characterized with a single insertion, consecutive larger core, and it's very sensitive for microcalcification. However, it's expensive and less available. So to conclude, the ultrasound breast biopsy is an accurate method for diagnosing of breast cancer with a false negative rate up to 4%. Determining of the imaging pathological concordance after biopsy is essential. The radiologist should be aware of the general aspect to consider when establishing the concordance and the correlation. Appropriate management, including the active communication with the pathologist, physician, and the patient should be performed, and the vacuum is more accurate and specific. And thank you.
Thank you.